I am here to talk about say challenges in laparoscopic myomectomy. Laparoscopic myomectomy. Before that, something you have to be sound in. That is what I believe. Like in any field, like as Vikram has said, like you have to be sound in something. Like you practice this one and you believe that this is the best, and that is the thing. So you keep on continuously doing the same thing and continue it. Another thing which I want to show you is as something, again I'll refer to Vikram. You should be prepared when you put the trocar, that is the interval, like many things, half of the picture is before that. So you should have lot of preparation. But this is something which I will show you where I have caught him unprepared. This is out of context. This is absolutely out of context. Can you see this picture? No? क्या है? Presentation. Is it seen? कहाँ है दिसत है? अच्छा, okay. Okay, this is the only thing probably seen in this. Okay, right. Okay, so we'll talk about this. I'll show you those things later. Okay, this is the picture we want when we do laparoscopic myomectomy. This is the end picture which we really want, and this is how it is done. So this is to make a point that your preparation is right, your previous steps are sound, your technique is sound. Then what happens is that the simple difficult thing which is said to be difficult, not actually difficult, but it can become very simple. This is absolutely unedited part of enucleation of the fibroid. So what is there in this? Actually within less than in a minute the large fibroid is out. Okay, but what was the step done before that? There are few things. That is what we say the challenges to reach to this stage of say enucleation. Now there is not much bleeding as well. You can see like there is no like too much of redness you are seeing. So that is also something which you have to achieve with this preparation. So challenges come when we don't know about the things. If you know about the fibroid, you know everything about the fibroid. What is the size of the fibroid, number, location, cervical, distance from the endometrium, its consistency also, because that is making a major concern these days about the myomectomies nowadays. I have few slides about that also. So fibroid mapping is something which we should be having this thing. If we have that thing, then it becomes very easy. But primarily, like grossly, if you want to see what can be the things, it can be a cervical fibroid where you counter problems with your vessels here, right and left uterines and the ureters. So the techniques have developed. Then broad ligament fibroid, where you have to plan a strategy to avoid injuries, to have a safe surgery. Then pedunculated myomas, we should know about it. It is not only the thing that pedunculated myomas are simple. There is one film which will go in short about that film also. When there is peduncle, what can happen to them? So if you have this kind of pictures, this kind of table and the details of the thing, I don't know whether you can read it, but there is something like the location, size and the grade also, and distance from the endometrium or some other specification. So there is a table kind of thing, and if you have this view and the other view as well, so you know how deep it is there in the endometrial cavity, where on which side is the endometrial cavity. Otherwise you can just see the bulge and you can incision on this side, you enter the cavity and then you extract the fibroid. It should not be the case actually. So this is how we come to know that whether endometrium is going to get opened or no. Now this picture is showing you about the details, like what is your planning about it, like what should be the port sites, how many the ports. I am absolutely okay nowadays that put you one more port and it is okay. It won't make any difference. Previous, like when we were like little immature, that time it was like putting more port. becomes like a stigma for us. It is not nowadays. About the manipulator, I am very keen we should not put the manipulator for the myomectomy, I would say. To explain it now itself, that when you put the manipulator in the uterus, it makes the vagina, cervix and the uterus in a fixed position, in the fixed axis. So the surfaces of the uterus which you want to access may not be accessible to you. For myomectomy, enucleation it may be okay, you can do that, but for suturing it will become very difficult if you can't access that port. Imagine that you are seeing from this side and your uterus is like this, maximum like this, and you have to suture on this surface. So your crater is here. So needle passing here and coming out here, and where is the bed seen now? No, it cannot be seen. For that your uterus has to go like this. This crater should be in front of your scope, and then you can see the lowest part of the bottom of the myoma bed, and then you can obliterate it. Otherwise it will become little guesswork only, that okay मैंने लिया है ठीक से stitches. That is how. So this is one point which I will make it. So one of the challenges of reaching or approachability of the fibroid is tackled. So that has solved my problem a lot. Wherever it is, like whichever surface, anterior, posterior, fundal, anterior low, posterior low, right lateral low, cervical, or even that is entering into the vagina, whichever place we can manipulate the uterus without putting a manipulator for the suturing and even enucleation as well. Two strategies which I have written here, like push the cervical lip. This is for low anterior, posterior or cervical fibroid. When you take out the fibroid, then what you do, if it is anterior, then I would suggest that holding the cervical lip vaginally and pushing it anteriorly. Automatically the fundus drops down, or somebody will hold it down, and the crater will be in front of your scope, because cervix is pushed anteriorly in the anterior fornix. If it is a posterior low fibroid, then hold the posterior lip, push it posteriorly. Your assistant takes the fundus anteriorly. You can support, or you can just hold the upper edge of the crater, and that crater is in front of you for the suturing. And this is okay, everything is okay as I am doing it ipsilaterally. My port placement is ipsilateral for suturing, because there is I am comfortable with lot of suturing is there in myomectomy, and I don't want to cut short or take any shortcut of taking few hemostatic sutures and taking 2 or 3 wraps on the this thing and saying that hemostasis is done, so it is okay. It is not like that. You have to actually put, this is a mesh of the suture material you are putting. Closed stitches are always good to avoid the hematomas, because you are not sure about it after the effect of vasopressin is gone, or whatever reason there can be some collection. It is going to affect your later output in the form of, say, pregnancy and all those things. So that is how your suturing has to be good, and that has to be sound. So all these tricks we have to use it. So blood loss prevention is one of the major factors during operation. What we talked about, say, post-op results as well, but before the approach of the fibroid, you should be thinking about your intra-op measures also. Anybody's pulse in the operation theatre should not move at all. Everything should be silent and quiet. So that is how you should be managed. The next slide is this, the similar kind of thing, but the thing which I want to show here is that the port is umbilical. So one of the dictum, as though these are young patients, we are doing myomectomies anyways, so this is actually not only for cosmetic, always comfort wise it is good that umbilical port can be taken for even larger fibroids. Only thing is you should have that you can say mental exercise, that you are not seeing the whole fibroid in a one vision, in one view. You can just observe the fibroid, and then you can put the incision accordingly. If you are taking the elliptical incision, you can just take it part by part, change the vision, take the incision, then change it. That is how you can just take the achieve the incision, and then enucleation part is very easy actually, according to me. Okay, so these are the port size which I will use for maximum fibroids, even though they are larger. This is uncommon actually. This is not like putting vasopressin, which will come later, but this is the first step to achieve the fibroid approaching to you. This fibroid is actually posterior, confusing. So taking away the sigmoid and making your left side of the pelvis free from the intestine, so that every time your instruments going and hitting the intestines and your assistant is not aware about that and having some injury, instead of take out these incisions, this is part of the adhesive lysis. Another thing after this is taking away the bladder as well, because that peritoneum is also holding your uterus in place as I want, and this is not for the anterior one. If it is anterior, it is obvious that you cut the anterior peritoneum and then your fibroid uterus can be reflected posteriorly and you can approach the fibroid, but this is not for that. This is for the posterior large fibroid where I am doing the bladder dissection. Why? Because that peritoneum is also holding it back. If you can imagine some surface and you want to just anti-flex the uterus, it is not possible with that. So you release all those things, and then at the end, now again I am facing the same problem that I am not able to take the video ahead. So I will do that probably this thing. But after that, the end result of this film, oh, it is not seen here also. Any solution anybody has? How to take the film ahead? I just want to. आता तर दिसत पण नाही आहे, तेच नका दिसत नाही. नाही तर मग चालू ठेवायला लागेल फिल्म, दुसरं काही नाही. माहिती आहे हे बघा नाही, मी थोडं लवकर संपवलं पाहिजे, नाही तर पूर्ण व्हिडिओ स्किप करायचा नाही. हा माझ्या शेताचा मागचा आहे,
केबल काढून लावू का?
आता स्क्रीनच दिसत नाही, येतो का थोडा वेळ? हां तेच ना, म्हणजे पण हे इतर वेळी येतं आपल्याला सगळं असं दिसतं, ते कनेक्ट केल्यानंतर काही नाही माहिती.
ह्याच्यावर तर फॉरवर्ड करता येईल ना, हा व्ह्यू पाहिजे.
याच्यावरती पण नाही ते फॉरवर्ड करणार.
In the meanwhile, till the technical problem gets dealt with,
बरं हे पण तर येत नाही ना त्याच्यामध्ये, हे कसं आहे?
let's have a small question answer session. So anybody has any idea like who did the first total laparoscopic hysterectomy?
त्याच्यात पण येत
So
नाही.
that's good.
नाही होत,
नाही होत.
नाही
सर
होत,
इथं
नाही.
स्लाइड शो मध्ये जा.
नाही होत.
हा याचा ॲपलचा आहे ना.
तेवढं 90 degree.
Now this is the last part of the actually we should take it ahead. Okay, so I have skipped that part. The posterior one fibroid, which was actually very easy to take it up from behind, it was occupying the whole pouch of Douglas, but I could take it like anterior, like a fundal fibroid, like made to order fibroid we call it. It was seen like that. Then next step is uterine ligation at origin. I think looking at the time, we may skip that. It's the same as like dissecting the pararectal fossa and go ahead. So I'll skip that. Large fibroid we call it. So what is the challenge? It's the huge, size is huge. But in that case, how large is this fibroid? This is not pelvis. This is actually the liver seen there. So that big is the fibroid. But what happens, like every time we see the records and everything, it is not necessarily that fibroid has to be like very difficult. See what has happened. The fibroid is all in the upper part. Okay. Sometimes you get like this, sometimes you may not. But to keep the thinking flexible, I would say like if it was in the upper part, why I have to go and land up into problems or struggle myself looking at the uterine at the origin only. It is seen in the isthmus level, internal os level. So I have tied it there. So your uterine artery ligation is done already there. So that part can be taken care of like that. Another point I will add, like not necessarily you have to do it bilaterally at the same place only. One side you are able to do it like that. Another side you can do it at origin. So your just the mental block has to be removed. So vasopressin, it is banned at places, but here at least we can use it, and it is a good device actually. I would say like good device. I mean, it is very useful. They suggest dilution of say 10 in 100 or 20 units in 200. But what we do, like you make it little safer. You just little tinge of vasopressin for all that vascular field. So I put 1 ampule, like 1 ml in 500 ml saline. कोण मोजत बसेल ते सरळ एक 500ची saline टाकायची आणि you dilute it with that much. So that is enough for us, and you can keep on diluting also if your field is larger. There are too many fibroids or the area you want to cover is larger. First you give 2-3 syringes, and then after that the sister keeps on dilating it, and you can keep it giving it. So your not dissection, I would say like aqua, you can say vasoconstriction can be achieved with little bit of vasopressin, which is needed that much only, not too much of vasopressin is needed. So that can be achieved with that. Because what I believe is not necessarily it is okay to give after one fibroid you enucleate, you suture it, and after that you give the other one, or you remove one fibroid and then you inject the vasopressin. That according to me or for myself it has not worked. Whenever there is any cut in the myometrium given, that vasopressin comes out from that, because I am giving lot of saline. That is why it keeps on coming out. So before you are cutting anywhere, you should inject it as far as possible for at one place, or if there are multiple larger fibroids, then one for each kind of thing you can cover the area and do that. So next thing and another thing is like when you give lot of vasopressin, my thinking is that you are taking 10 cc, 20 cc syringe, I would take 50 cc syringe. This is what I am doing nowadays. Take 50 cc syringe, you are putting every time, my imagination is like when you take, every time you take out the syringe and then put again, so your point where the needle tip is there, it may change its point. Okay, so it may, now it is not in the vessel, but when you do all these maneuvers, it may change and go into the vessel. You check every time, that is okay. But if you have larger syringe, you have to check less time, I would say. You inject slowly, not necessarily you have to inject very fast, but do it that way. That is what I am thinking. Then this slide is showing us about say actually transplant, uterine transplants. The principle or the basis on which it is dependent is like you need only one artery and one vein for the uterus to sustain for that time. So here also what we can do is like you can ligate both the uterines and you can ligate both the infundibulopelvic also. This is all temporary ligation. You are not going to tie it permanently. You can just take out this thread any time, because we know this trick knot. Our friend Dr. Sanket Pisat has devised the needle as well, and this trick knot as well. So that has helped us. So you just take it, you can release it in between if you want, otherwise you can keep it. It doesn't make any difference. That is practical way. Out of the hours you can note it, but doesn't make any difference. So you can release it at the end. What I am doing, you can release it and keep the thread. It is a piece of Vicryl actually. So you can just open it and keep it like that only. You will not have to take it out every time. Where it is going to go? Nowhere. So you just keep it there. If you feel that is lot of bleeding, you again tie it there. You finish the surgery like that. Okay. So that is how. And about uterine artery, even if you ligate permanently, it will not make any difference, because your internal ligation also you are delivering the patients later again. Okay. About the incision, that is the important part. This will sound like I am telling about laparoscopic myomectomy, but the thought behind is like you have one technique sound, so your fibroid can be anywhere like, so then you can tackle all that fibroids. So the strategies after doing many myomectomies or whatever I have realized are these things: incision, what I would say, like you can use any energy or scissors, it is okay. My opinion, I will say I will use this kind of PCO needle. I mean like very pointed object with a current, monopolar current, because this takes you 2-3 seconds, but with scissors it will take lot of time probably if it is thick, because it is not always a cakewalk kind of fibroid. Location is also very odd. In that case, you have to reach all the surfaces. Very huge fibroid, you cannot reach with the scissors from this side, though you can reach from that side, but sometimes difficulty is more than that also. In that case, just touching and cutting the myometrium helps a lot. Only thing is that you should be aware that when you have reached to the surface, that you should be aware, means your eye should be trained, your senses should be awake. There you just reach the surface and then you stop. At times it is okay. Now next step is like, it is okay to go little bit, half millimeter, 1 millimeter into the fibroid is okay, but it is not okay staying outside the fibroid or in the false capsule, because that 1-2 millimeter difference in the staying in the capsule is going to get reflected when you go down to the endometrial cavity and you are going to enter into the endometrial cavity. So when you have race against this saving the endometrium, that time that 1 millimeter difference also is a little significant. I mean very significant. If you are in a correct plane, you can say only endometrium. You can see a endometrium like a bulge, like a balloon you can see. But that also helps in case of fertility, as you have not touched the endometrium, that helps a lot. So this is how, these are the basics of laparoscopic myomectomy, which will be useful to tackle any challenge in laparoscopic myomectomy. That is how all these like conventional kind of talk or presentations and films are there. See, we are cutting layer by layer. And about incision, if you ask me, I am fond of, fan of and convinced about say elliptical incision. Elliptical means not always elliptical. If it is very superficial kind of fibroid, then you can take a large, go around the fibroid and take it. If it is a little deeper, then your circle narrows. If it is deeper and moderate, say medium size, then it can be a linear incision. So that is how we decided. As you go deeper, your size of elliptical incision reduces. That is what we should do. Another thing what you can do is like elliptical incision, it helps to reduce the redundant tissue. That is one thing. Apart from that, your suturing becomes easy. It makes it shallow. What happened? Okay. It makes it shallow. Again, I'll run this film which is we have seen before of the inoculation. So my opinion about elliptical incision is that it makes the thing shallow and apposition will be easy. It is not like pulling it too much together. That size has to be, there is some judgment you have to apply. It cannot be like widely open uterine crater. It should not be like that. It should be easily approachable kind of, that should be the size of the elliptical incision. One variation you can do is like a smile you can see. You take a small ellipse, take that part of myometrium can come out, and then laterally you can just incise like a linear incision. So that will also make the things little easy in case of suturing. So this is enucleation. For that we follow these tips, very universal. You fix the fibroid with the myoma spiral. As I am ipsilateral, I won't give the myoma spiral to the other person. It will be in my hand only, because it has to be changed many times. And it has to be close to the site of shearing. So apply it there, exactly at the good smooth surface of the fibroid only. No myometrial fibers in that. So apply it there. Use a claw forceps, 2x4 forceps, or tooth needle holder, or any instrument you want to use it. Hold small bites of the myometrium just next to the myoma spiral or from the fibroid. You don't have to hold from serosa to the false capsule. It has to be very small. It is just shearing it from the myometrium. Then only it becomes easy. If you try to take larger bites, you need lot of strength also, and it becomes little difficult after that. So, and change the myoma spiral sites regularly or frequently, so that you are staying close to the shearing place actually. If needed, sharp dissection. They used to say like there is a pedicle always, but it is not actually. No pedicle is seen usually. But if it is seen, you mind that you may have entered to the myometrium, or if there is any vessel, you just cauterize and then proceed. The normal technique of fibroid enucleation and this thing we have seen, here we tried the same way, but it was not possible. Now the challenge here I would just mention is of the smoke. You would say, like, why to use monopolar instrument if there is so much of smoke. So for that, what we do, we give suction cannula in the other person's hand, and that person, if it is reasonable, they will definitely do it. Like when I am not running the current, that time they will suck the smoke. When I am using the instrument, they will not. So that smoke quantity also can be removed from the peritoneal cavity without causing any harm to the other people. You don't have to keep the thing open continuously, the cannula or something. So here we have abandoned that thing of, say, myoma spiral, that we cannot do it. So your grasper and your other instrument plus this traction, that is very, very important. Like your bladder dissection, if somebody holds the bladder up, that then only you can do it very easily, or you yourself are holding the bladder up. Similar way, here this traction is very important, and slowly you run on the surface of the fibroid. Here no chance of holding the two things strongly and pulling it up. So that is how we enucleate these kind of degenerated fibroids. Any instrument you can use it, but one with a good grip, that can be used. The needle is helping only because if needed I can cut few fibers, that is why needle, otherwise any other instrument also is okay to do that. Now here unfortunately I cannot take it ahead, so I am not able to do it. It was so close that into the uterus that it is close next to the endometrial cavity. Okay, so that is how it is removed. So we'll just move to the next thing, closure. One incident I always tell, that when I started using this barb suture, when it was like first brought by John Inarson in Cochin conference, that time I had 2 pieces of barb suture with me, and in Mangeshkar hospital after vasopressin, that time it was not 550 cc or something. So that time she had peripheral vasoconstriction, so our anesthetist was little jittery, so we had to stop after that sometime. Then he said, okay, slowly you start and all those things, but then and you try to finish it early. If it is not okay, we'll open and all those things. And the fibroids were like 1 deep to that, so it was a big crater that time. And I was also like very keen about taking out too much of the myomectomy or elliptical incision, so it would take time kind of. So that time, first time I said, okay, I'll use this. It was with me. I sutured with that, whatever they have told, and it was so convincing that this is the best thing for myomectomy. I mean, it was a boon for myomectomy. That suture material, we can use it anywhere, people are using it anywhere, but it is actually very like perfect thing for the myomectomy. So what happens is, this barb will not make it loose. So I don't have to tell the advantage of the barb suture, you don't have to put a note or something. About the closure, what we say, that single layer or multiple layer, it is up to you. There are papers that if you don't have dead space, then easily you can go along with single layer closure as well. Intermittent vicryl stitches, okay, no problem. Double layer vicryl continuous suture, it is okay. Just don't leave the dead space and have a good approximation. That is the only thing. The method of approximation always conventional, like serosa to serosa, but few things noted about barb suture, so that your momentum, this thing may get entangled into the barbs, and they may have, say, intestinal obstruction. So for that you have to have less suture material exposed. In that case they used to like baseball suture, like inside out, outside, inside out kind of suturing, all inside outside in. So that kind of suture you can take it, but I am not very keen. I have not faced any, because I suture it in layers, like inner 1 layer, 2 layer, 3 layer, whatever needed, so that your suture material outside, you don't have to go too far from the edge on the serosa, so that your stitches are close by, so not much material is exposed to the outside. And plus we keep some material on that, so that it is not exposed to the intestine or the omentum directly. So this is like deeper crater here, so you can take it like in layers. I always prefer to do it in 2 layers, and if it is like too deep, then 3 layers, whatever it is needed. It is not like our choice. I would take it like this is the fibroid would decide what has to be done. There are different ways of suturing, as I said, like your box stitches, like go from one side, enter from the same side, come out through the crater, come out through the other myometrium and enter from the same side again, so that you can cover the hemostasis part and then just approximate on the outer surface with your regular stitches. That you can do it. But still, all these years I am doing this, and many myomectomies done, many pregnant and delivered at many places. Touch wood, I never had any problem, or anybody has told that your uterus was like that and there was a rupture after myomectomy, nothing like that. So I am still convinced. That is my technique. I would say, like, this is one of my favorite ways of doing it. And barb suture has made it very easy. So you can just run the suture. I am very specific about that also. I would not use like 45 centimeter barb suture. I will not use your symmetrical barb suture. It is normal barb suture, which is 30 centimeter, 36 centimeter, not more than that, because that gives you huge advantage of faster pace of suturing. You don't have to pull it, the needle. It is kind of say prolene stitch. So there is lot of entanglement of the suture material, which doesn't happen with your 30 centimeter suture. So I will use like bidirectional suture material, which has got 30 centimeter. I will tie a knot at one end, which will act as a stopper, which company will not like anyways, but still we are doing that. So if you want to use, you can start from the other side, and you can cut it in between and use it. No need to use both the needles at a one time in the peritoneal cavity, hang it somewhere. So not that jugglery needed anywhere. So that is how it is done. So this film I can't skip anyways, but this is how we'll do it. Like even if thicker, this is huge, this is thick myometrium, but still we are able to approximate. Once you take the sutures of the inner layer, your serosa comes closer. But still, if by mistake, suppose you have done wrongly, a large elliptical incision you have taken and your edges are quite away, then what do you do? One stitch, I don't know, you must have seen it, like kind of say purse string suture, but purse string not, you can say horizontal. This purse string is vertical purse string. Start from just below the serosa, take a good bite, then very thin bites up to the base of that myoma bed, come out from the next serosa with a good bite. And if you pull it, the serosa come together, and your dead space is also obliterated with those thin bites there. So that is how your problem which you have created with your larger elliptical incision can be overcome. And then when they are together, if serosa are close to each other, you can take your normal stitches. So that is done, and with that hemostasis is never a problem anyways. So this is something we are running on the surface. So I will just go to the next slide, we won't go into that. This is the abgel keeping on the surface. So abgel may not be a very authentic thing to keep it, but it helps a lot, and very you can say economical, easy to keep. It is not like difficult to handle. Then submucous fibroid, a fibroid inside the fibroid. In that case, what you do, like you can go from the same incision site and take it out, and you have to suture. But for that, you may use your box type of sutures to obliterate in case if you are not easily approachable. These are twisted fibroid. I said that it is not pedunculated fibroid always easy. This is what can happen here. What like the veteran people can identify what has happened here. These adhesions are very flimsy. They are not. This patient had a history of pain, and then she came together, because otherwise she never had any problem. So she had pain. She comes together. She comes to a doctor, and then what happens is a diagnosis of something like some mass. And what happened? Like though they say pedunculated fibroid, no vascularity. This is what can happen to a pedunculated fibroid, that it undergoes torsion, and then it tries to get blood supply from. So that is this is actually the attempt of the fibroid to take the blood supply from the surrounding structures. That is what it is seen here. So we separate it from that, and then at the end we can just come to the base of that fibroid, which is just a small pedicle, like ovarian torsion, like an ovarian torsion. And as its shape is like kidney shaped, bean shaped, so then it is difficult for it to go back to its normal position once it has undergone torsion. Okay. So these lobes here and there, they make it difficult for the fibroid to come back to its normal. Untwisting cannot happen on its own, and once these surrounding structures start sticking to it, then it becomes difficult, it becomes fixed like that only. So this is how it has happened here. I'm just waiting for this to reach to the base. These are the adhesions which we are releasing for the other port actually. We could not put the port because these are adhesions of the previous surgery or something. And then you just go down. It's a very delicate job has to do. These are not like adhesions which I won't take any credit of this adhesive lysis. Only is that gently you do it, and now you are able to see the uterus, fundus and left side. So the uterus is down there. All this blue thing is fibroid. And what you have to do is, this fluid is taken anyways for, because there was a lot of fluid inside. So we take for culture sensitivity and send and all those things, if something like that. So you just have to cut the pedicle and detach it and take it out. This is the fibroid. I was going to ask you like what is that, but it is supposed to be cervical fibroid, but as you remove the peritoneum, you dissect nicely, only small pedicle attached to the posterior part of the uterus was there. So I'll just skip that slide. Then morcellation, there is a big, you can say like in international conference you can talk about morcellation. In India we used to do all those things. We do morcellation. Sometimes we are for open morcellation, or somebody is there who will you can say that it has to be done like in bag morcellation kind of. So our opinions were divided still in India, but this is something which we should be aware. And my word of caution that surgeons and oncosurgeons and other people as well, so this should not happen and suddenly we are seen as a villain in your laparoscopy. So all these things can happen because there are cases noted, because we have tumor board and all those things, they have all these cases. So they are quite against morcellation, but good imaging, knowing the fibroid very well, needed MRI and whatever needed you should do it, and your histopathology, immunohistochemistry, many things have changed, so we should not be delayed in all those things. That is what I suggest. Endometrial stromal tumors, sarcoma, they have division, low grade, high grade. Imaging very necessary. You can just say that it is a degenerated fibroid, but it is not. If something turns out to be like that, your normal lab may give you a report of say fibroid, degenerated fibroid, something like that, because they may not be expert in that. But there are labs, and nowadays like people are very much aware that it can be sent to the Borges lab and it will come as fructose dehydratase deficiency syndrome. So it has to be checked. Later she develops renal cell carcinoma, because in that meeting there are medical oncologists also who had these cases of renal cell carcinoma, and retrospectively they are taking out the histories, like she has undergone myomectomy 8 years back, 9 years back, 6 years back kind of. So cases are not there, it is not the case. There are cases, so we should be aware. So I would promote that in-bag morcellation should be done. Okay, we cannot do it these days. Previously it was okay, but nowadays it should be done, because people may take you to the court as well. Sarcoma, it is not like leiomyosarcoma. We say that leiomyosarcoma is very rare, but it's endometrial stromal tumor. In my practice also I have faced this endometrial stromal tumors. Luckily it was not sarcoma, but it has happened, like somebody has done hysteroscopic myomectomy and half was removed. I did it laparoscopically later and it turned out with this kind of tumors. Then other discussions. These slides are just to emphasize that this is something very big in our field actually. So we should not be neglecting all those things. LGESS, like what they call, they will talk about like LGESS, ESS, like very commonly it is happening kind of, and we are not aware about it. That should not happen. Showing the results of open morcellation and closed morcellation. So the disease-free survival is significantly different in cases of early. Then recurrence is too much. The significance is huge, 7.4% and 31%. So these are like, it has been studied. We should not get caught unaware. That is what I just wanted to make. All strategies are fixed actually, what should be done. Even fertility is also thought about. Like low grade ESS, it can be like after fertility it should be removed, not removed. Everything is discussed, so we should be aware about it. This in-bag morcellation, not very difficult, not a challenge. It's just few minutes more and it can be done. This is how it looks. I'm just putting pictures and video to be aware that it is part of our myomectomy. I can skip that, but it is very important part of the topic actually. So this will look like that, like fibroid is in the bag, one end is out from say lower part, left lower port, and scope is from the upper port, which is both the things are in the bag itself. The bag goes inside, it is opened, the fibroid is put inside. Then what happens? Then the bigger mouth of the bag comes out from the morcellation port. So you are seeing the bag from outside. That is the first step. After that, what happens? Then you are taking out the tail, means the part of the bag, the track of the bag, which is made to put the scope inside, which comes out from the umbilical port. Okay, it has got typical way of opening is as well. It has got, now this film I cannot just fast forward, but you just have to hold that tail, which is actually the port for the scope. You just have to pull it, it will come here. Now that is the one which is there, which is rolled in that way. So you just have to roll it so that bag also gets opened with that. So we have taken advantage of that one to open the bag. Okay, so now the bag is opened, then the fibroid goes in the bag, it comes out from the side, and this tail we are pushing it with one instrument through the scope port, and then give a nick to it outside your abdomen and put a scope inside. So when your scope goes inside, then both the things are in the bag only. Now COT is going into the bag and morcellate is also going into the bag, and then you are morcellating. So the other person is not able to help you. That is one of the disadvantages, but is not needed. Why? Because it makes a globular thing on which the fibroid can slide. So if you give the little head up position, the fibroid is in front of you, and most important technique you wanted to follow whenever you used to do morcellation is that fibroid should roll and come out, like roll on the morcellation. So that happens because this plastic round shaped smooth surface of the new cavity, so it will keep on coming in the form of say onion peeling kind of thing. So that is how. So I just wanted to emphasize that this is how it has come. The knot is formed. When I am going to remove it, I will take out the scope, I will make a knot to that port and then push it inside the, this is the knot I have done. I'll push that one into the peritoneal cavity. So one end, which was the scope end, it is now closed. It will go inside. As it is little bigger knot, I'll just push it with the artery. Alice, it is going inside. It is still, pneumo is still there, maintained. Okay. And after that, I will not remove the morcellator and then take out the bag. The morcellator is in my hand only. So the whole thing has come out as a whole. So there is no spillage of the fibroid inside at all. It looks tedious, but when you start doing it now, it is very easy and very convenient, because you don't have to keep on cleaning your abdomen continuously with your irrigation and suction. Now just few slides to show there is something which is very conventional. Like you cannot neglect our normal laparotomies when there are situations like this, or if somebody is giving you reports of something bad, then this is not very big uterus actually, but the fibroids and those were very bad, very bad, very bad. So for that, what we have done, we have taken out few fibroids, laparoscopic, larger ones, so that your job is done with a smaller incision. So you, with the smaller incision, you can repair the uterus. The repair of the uterus, I am not saying that laparotomy for multiple fibroids is not the case. It is actually like this. So cervix is somewhere else and the cavity is somewhere else. You can see just a track. So you have to attach that, because the location of fibroid was like that. So in such cases, It is not necessarily you have to be dogmatic about your laparoscopy skill, but reconstruction is more important. Something like plastic surgery we have to do. This is also not the last picture. Last picture is much better, but this much I could get in my records. So this is how your uterus comes back to normal. You cannot compromise the integrity of this thing. Complications now, it is like regular complications of all the laparoscopies, because that is also one of the challenges. You should not land them into a rupture or something. That is one more important. Infection should not be there, and sometimes unexplained renal failures or deaths are there. I have not faced those things, but those are noted, so we should be aware about this. So your good laparoscopic skills, those help. Your principles of surgery, if you follow, that helps, and consistently doing with one correct technique, that helps. And you are not important, your patient is important. That is the most important thing. Thank you so much. Thank you so much.